Hello and welcome to the July Oncology Coding Break on Female Reproductive System, Ovary Anatomy, and Staging Guidance. My name is Heather Donohue, and I will be joined by Melissa Meador to once again lend her expertise in anatomy and physiology. As you may have noticed, this coding break is part one of a four-part series. July through September will focus on anatomy and staging guidance for ovary, uterus, and fallopian tubes, cervix, and vagina. And then we'll put it all together in October for a special 1 hour live coding break worth 1 CE, where the presenter will focus in on histologies, grades, treatments, and case scenarios. So be on the lookout for more information and how you can get registered for that. Melissa's going to start us off with some female reproductive anatomy and really break down the relationship to the peritoneum and where the true and false pelvis begin and end, what organs and structures are contained in that area, as well as discuss the different ways ovarian cancer spread. And then I'll give some helpful tips and pointers on how to get that staging correct. You might recognize these images from the colon presentation because once again, in order to be successful with staging these cases, we will really need to understand the anatomy, have good investigational skills, and really tap into our critical thinking. Accuracy really depends on utilizing these skills, practicing diligence, and using all manuals and resources available to us.
Okay, so today we are going to be talking about ovaries and cancer from ovaries. So we're going to start off, this is a sagittal section showing the abdominal pelvic cavity, and if you watched the colon coding break that Heather and I did, we showed you this same picture. There we were talking about the parietal peritoneum with the colon. Now we're going to be talking about the parietal peritoneum with other things. So we're still going to be lined with the parietal peritoneum. So here's again is the parietal peritoneum. Then it's going to be coming around, and remember we're going to come around, and then there's going to be several organs that are retroperitoneal. The pancreas, the aorta, it's not on here, but also the kidneys are. So this whole area now is going to actually be the abdominal pelvic cavity. And there isn't a distinct membrane that separates the abdominal cavity from the pelvic cavity. This is different. You know, the diaphragm is going to separate this abdominal pelvic cavity from the thoracic cavity. But there's nothing to separate the pelvic cavity from the abdominal cavity. Now, in anatomy, if fluid can move from one area to another, it is said to communicate. And so the fluid can communicate between the abdominal and pelvic cavities because there's no membrane. On the other hand, fluid cannot cross the diaphragm, so the fluid from the abdominal cavity cannot communicate with the thoracic cavity. And so that's why things going on in the abdominal cavity don't spread automatically to the thoracic cavity. So now in this picture, this is one of the models that I used when I was teaching, and I really like this model a lot, the three-dimensional model, just to help to give you some idea of it. So here we've got this parietal peritoneum again, and it's covering the bladder. So here's the bladder, here's the peritoneum going across that. This is the uterus. So the parietal peritoneum is going to cover the top of the uterus and then go back up the back side. And so the part of the peritoneum covering the uterus is called the broad ligament. And this is a picture, you've probably seen something like this before. And here they've got it's labeled the broad ligament. And the broad ligament just sits over the top of it, and it helps to support the uterus some, and because it's going to come all the way to the side walls and to help attach it. But again, the uterus is retroperitoneal, and so it's the peritoneal cavity is going to be up in here. Notice also parts of the broad ligament are going to cover the fallopian tubes and the ovary. So this membrane is going to be covering the top of a lot of those. Then On here, this is a cross-section through that same model. And so here you can see the bladder, you can see the uterus. Any of you that have been 9 months pregnant, you're thinking, yeah, now I understand. And why? Because when you're 9 months pregnant, the uterus is going out this way, and it's just sitting on that bladder. Now, one thing I want you to notice is the folds of the peritoneum. See, it folds in, and now it's going around the uterus, and then there's another fold back here. This is the vesicouterine pouch, and here's the rectal uterine pouch, which is also called the pouch of Douglas. And so those are formed by the folding of the peritoneum. And again, those are things that you will see. The surgeons will refer to that, especially when they're trying to clear out some myths. For cancers of the cervix, vagina, and ovary, staging depends on extension beyond the pelvic brim. And so for these, it is necessary to understand the anatomy of the reproductive organs compared to the pelvis. So this is a picture of the pelvis that I used to use when I was teaching. And so what we have here is the pelvic brim is formed by the pubic crest. So here's the pubic crest that you can feel on your body in the front of you. And then it goes around the side. This is the iliac bone. This up here, the iliac crest, this is where they do the bone marrow biopsies. And then see this kind of suture lines there? This bone here is the sacrum. And it sticks out in the front, and that's called the sacral promontory. And if you read, the surgeons will use that as a landmark a lot. Well, the sacral promontory is part of this pelvic brim. So this pelvic brim, again, it goes from the pubic crest to the iliac, and then from around the sacrum. And below that is the true pelvis, and above that is the false pelvis. And as I used to always say when I was teaching, the true pelvis is what is truly hard to push the baby through. The baby falls down into the false pelvis just fine, but getting it out through the true pelvis, and that's actually what it's named for, is for the descent of the baby. So it's important to understand the relationship of the true pelvis to the rest of these organs. And that's very hard to visualize, even in a lot of the pictures that are in our AJCC model and things, manual. So what we've got here is going to be the symphysis pubis. And again, I'm picking out the part where it sticks out the most. That's going to be our sacral promontory, and I'm drawing this black line. So everything in down here is going to be in the true pelvis. So the bladder, the uterus, the sigmoid colon, ovaries, fallopian tubes, those are down in the true pelvis. And then we're going to have an area right above it with the false pelvis. Now, the next thing to remember, too, with ovarian cancers, 90% of the ovarian cancers originate on the surface of the ovary. These are going to be the high-grade and low-grade serous carcinomas. And they're called serous carcinomas because they start on this serous membrane, that parietal peritoneum that's covering the top of them. So they're not really starting it down in the true ovary. It's this membrane over the top of the ovary where it's coming from. Well, because they are surface cancers, they can shed or spread through seedling. Well, as we've said, there's no membrane in here. So once these cells have shed, they can go and land. So they can land on the outside of the uterus, they can land on the bladder, they can land in the this area back in here. All I can remember is Douglas, but or it can go out farther and land on the intestines, which are going to be up here. Okay, so now let's review which organs are in the pelvis. The true pelvis is going to include the bladder. Let me grab this. So the bladder down here, and the uterus, the sigmoid colon, and the rectum. The false pelvis is going to be just above that. So over here, this would be the false pelvis up here, a little bit higher. It's going to contain the lower portion of the descending colon and parts of the small intestines. The majority of the small and large intestines are in the abdominal cavity. Also, the greater omentum. So this is the greater omentum. Remember, this is the membrane that is a continuation of the peritoneum, and it's going to hang down in front of the intestines. It covers the top of the intestines. So this is going to be the greater omentum. And then finally, let's remember the organs that are going to be retroperitoneal, such as the pancreas, kidneys. You can't see it here, but the kidneys are the aorta itself, the inferior vena cava, pancreas, and there's all kinds of lymph nodes back here that are retroperitoneal. When serous cells seed from the ovaries, they can land on the surface of the abdominal organs or on the omentum. This is different than cancer cells moving via lymphatics. That is why there's a difference between liver or spleen surface involvement. So if it lands on the surface of the liver, that would be from seeding, and parenchymal mets, which would come either via blood or lymph. And because the kidneys are retroperitoneal, you wouldn't expect surface mets there. Then the last thing, just to kind of review too, is the different regional and distant lymph nodes. So as we're going through here, we've got the para-aortic, and again, the peritoneum sits on top of the aorta. So all of this is going to be retroperitoneal. We're going to have common iliacs. We're going to have sacrals. We're going to have an external iliac, internal iliac. See, the internal iliac is going to go down more towards the ovaries and uterus. Remember, the external iliac is going to leave the leg, leave the pelvic cavity and go into the leg. Obturator also right there as it's leaving. Now the inguinal, these are farther away. These are not regional to the ovary. They are considered distant. And actually the flow from the lymph is going to be going up. So if it's gotten down to the inguinal, that is definitely not going to be regional.
Excellent. Thank you so much, Melissa. Great information as always. And now we'll see how important that anatomy really is to getting this staging correct. So when looking at AJCC staging, in order to even stage the case, you have to have microscopic confirmation. So we have to have confirmation that this is an ovarian histology, and then we can move on with staging. So first and foremost, when we get to that T value, do we have that confirmation? If yes, we can go ahead and assign the T value. When we get into assigning the T categories, we must have microscopic confirmation of peritoneal implants beyond the pelvis. When it comes to lymph nodes, again, we need microscopic confirmation. We cannot use imaging alone. So in order to assign an N value, we have to have that microscopic confirmation. If we don't, we cannot assign an N value. For Mett's disease, we're talking about parenchymal involvement of the liver and spleen, sites beyond the abdomen, distant lymph nodes, and pleural effusion. If we have any of those, then we can assign an M1 value. So when we talk about the liver and spleen, we have two scenarios here. So first is surface. Any surface involvement is T3C and not captured in the Mett's category. Parenchymal involvement, or that lymphatic spread that Melissa talked about, is M1 and not captured in the T3 category. So focusing in on T2 and T3, where the complexities really come in and where we really need those strong anatomy skills, So T2, pelvic extension below the pelvic brim. So again, Melissa showed us this great cross section here. So we have this kind of imaginary line that we drew here in blue. So anything below this blue line would be T2. So thinking uterus, fallopian tubes, and other tissues there. T3 is microscopically confirmed peritoneal mets outside of this true pelvis, so above the pelvic brim, above this blue line here, any of the structures above. So that would be the false pelvis and the abdomen. And then from there, our T3A category is microscopic, so not seen with the naked eye. Our T3B category is macroscopic, but less than or equal to 2 centimeters. And then our T3C category is macroscopic, and those implants are greater than 2 centimeters. This is also, again, where we do capture any involvement, surface involvement to the capsule of the liver and spleen. So again, just to reiterate, we need to be very careful about what the involvement is when it comes to liver and spleen. Are we talking surface or are we talking parenchyma? That will make the difference between capturing in the T category or the M category. I also want to point out that the T3 category does include the greater omentum. Okay, so now EOD and SEER Summary Staging. So I skipped over localized. That's pretty straightforward. Again, focusing in on more of these complexities. So pelvic extension, we're talking below the pelvic brim in the true pelvis. If the disease is just there, then we would use an EOD 400 to 500, and that would be a regional bidirect extension. So again, Melissa showed us this cross section we have here. So we have this now that imaginary kind of line that separates the true pelvis from the false pelvis and the abdomen. So any of those structures in the true pelvis would be localized or regional bidirect extension. So regional bidirect extension would include things like the adjacent peritoneum, the bladder, the cul-de-sac or pouch of Douglas, so those folds Melissa talked about, any of the ligaments, the perimetrium, pelvic wall, sigmoid colon, rectosigmoid, and rectum, and the pelvic portion of the ureters. And then we have peritoneal implants. So when we get to peritoneal implants, we're talking beyond the true pelvis, above the pelvic brim. So again, above that kind of imaginary orange line that we're seeing. So here and below this kind of orange line here that separates the abdominal and the thoracic cavities. So we're looking for microscopic or macroscopic disease, and we are going to code EOD 600 to 750 depending on those specific criteria, and that would map to a distant summary stage. So I just want to take note here that seeding on the liver or spleen surface is coded in EOD of the primary tumor 700, similar to what we saw with AJCC staging. When we talk about EOD mets, we're looking at code 30, that would be distant lymph nodes, and most of the time we're seeing those as inguinal lymph nodes, and then the pleural effusion. Code 50 captures liver and spleen parenchyma mets. So again, your surface involvement is going to be EOD of the primary tumor, and parenchymal involvement will be EOD of the mets. Okay, so when we're abstracting these ovarian cases, we do have to do that groundwork. So first, again, we're going to tap into those investigational skills and really determine the primary site, which will require histologic confirmation for staging. From there, we'll need to determine all organs and structures involved. Then we'll need to tap into the critical thinking and anatomy skills to determine where that disease is located. Is it below the pelvic brim, above the pelvic brim, in the abdomen? Is it beyond the abdomen? And then from here, we can determine our AJCC staging, EOD, and SEER Summary Staging. So let's take a look at a case scenario. So there was an exploratory laparotomy. There was a 16.3 centimeter pelvic mass. This did invade the bilateral pelvic sidewalls and bladder. Ovaries were not visualized, and the uterus and cervix were already surgically absent. There was peritoneal carcinomatosis. The sigmoid and transverse colon were involved by implants, 1.6 to 2.2 centimeters. Liver surface implants were also noted, 2.3 and 1.8 centimeters. There was omental caking due to peritoneal mets. There was complete debulking that was would be the preference for the treatment for this patient, but the physician did state that that would require a radical surgery. So for that reason, biopsies were obtained and the bladder tumor only was debulked. Tumor debulking of the bladder took place again, and biopsy of liver tumors, omentum, sigmoid, colon nodules as well. Pathology did show that the bladder tumor was high-grade serous carcinoma, and it was consistent with an ovarian primary. And then liver, omentum, sigmoid, colon biopsies were all consistent with Mets serous carcinoma from the ovary primary. So PET scan showed, again, the large ovarian mass, extensive retroperitoneal lymph node metastasis, hypermetabolic lymph node Mets with index showing bilateral external iliac, para-aortic, and pelvic lymph node metastasis, largest 12 millimeters, and then inguinal lymph node Mets, 12 millimeters. Liver surface Mets were also visualized, and they did recommend an MRI, and there was extensive hypermetabolic peritoneal implants. So when I'm working on my ovarian cases, I like to use a checklist. So this wouldn't be a bad idea to also incorporate this tool into your toolbox when you are abstracting your ovarian cases. So as you can see here, I was able to check off all the boxes and see exactly where those structures are located, and then go ahead and assign my staging based on that. So we had trigopelvis involvement. We didn't have any involvement in the false pelvis, but we did have abdominal cavity involvement. We had colon macroscopic involvement. We did have involvement of the omentum, but they didn't give us a size. But since it was seen on imaging, I guess that would be macroscopic. And then for the liver, we had macroscopic liver surface involvement, and we didn't have any organs beyond the abdomen. We did have regional lymph nodes, but that was imaging only. And we also did have distant metastasis by distant lymph nodes, inguinal lymph nodes, and that was on imaging as well. Okay, so putting it all together, I came up with the primary site of ovary, and that was based on that histologic confirmation of high-grade serous carcinoma of the ovary. My organs and structures, I had those all listed out, and my lymph nodes I had listed out on my checklist. So then I moved into my critical thinking. Again, what did I have there? I had organs below the pelvic brim involved, I had organs in the abdomen involved, and I had lymph nodes. So those lymph nodes, the retroperitoneal lymph nodes, they were not microscopically confirmed, but they are regional to the ovary. And then we also had inguinal lymph nodes. These were distant and, again, just imaging. So not microscopically confirmed, just imaging. So AJCC, I came up with a T3C macroscopic Mets beyond the pelvis with retroperitoneal lymph node Mets and liver surface Mets. NX, I said NX because there was a surgery and there was no microscopic confirmation of those nodes. So nobody can assign an N value because they did not go ahead and take out or biopsy any lymph nodes. And then M1B, inguinal lymph node Mets, so that would be a C, M1B, clinically only. We did have imaging to confirm those distant lymph nodes, and they do not require microscopic confirmation. The stage group would be 4B because any N applies, so T3C, any N, M1B, stage group 4B. Our EOD would be EOD, the primary tumor, 700, liver surface implants that were macroscopic. EOD of the lymph nodes would be 400. There was regional lymph node Mets greater than 10 millimeters. EOD Mets would be 30 for those inguinal lymph nodes, and then the SEER summary stage would be distant. And that's all we have for you today. We look forward to seeing you back in August for part 2 female reproductive system, ovary, and fallopian tube.